Welcome back to The Deep Dive, the show where we take a stack of dense, complex information, in this case, the highly quantified mechanics of drug efficacy, and turn it into a streamlined knowledge snapshot just for you.
Today, we are decoding the language that dictates safety in medicine, pharmacokinetics. This isn't just theory, it's the math and biology that determine why one person gets better, and another might experience dangerous side effects even when taking the exact same dose of medication.
Our mission today is to really explain the fundamental equation of drug effectiveness. I mean, why are some life-saving drugs just simple pills you swallow, and others, sometimes for the very same condition, have to be injected right into your bloodstream? The answer is, it's buried in those calculations.
That answer is pharmacokinetics, or PK. Yeah, PK is literally the study of what the body does to a drug over time. To simplify it, we break this down into 4 core critical processes, which you might know by the acronym ADME.
ADME, right, so absorption, distribution, metabolism, and excretion. Okay, let's try to unpack this from the drug's point of view. So absorption is just the drug successfully getting into the main circulation, right? Whether it came from a pill or a needle. Then distribution is its mission to spread out and find the targets in the body's tissues. And metabolism is the body fighting back, trying to change the drug, usually to inactivate it.
And finally, you have excretion. That's the final clearance, getting it out, usually through the kidneys or in your feces. These 4 steps, they are the absolute pillars of individualized dosing. We need to know not just the dose we gave, but the concentration that's actually working at the receptor sites at any given second.
So understanding this whole ADME relationship is really the only way a doctor can get the maximum benefit for a patient at the lowest possible risk.
That's the goal.
All right, let's start the drug's journey with section 1, the body's filter. We're talking about absorption and this thing called the first-pass effect. The moment that pill hits your mouth, it's a high-stakes obstacle course for the drug, starting right away with absorption.
It truly is. Absorption is that critical process of moving the drug from where you put it into the systemic circulation. But first, especially with pills, the drug has to undergo liberation.
Liberation? You mean it has to break out of the capsule or tablet?
Exactly. It has to be released from its dosage form. If it's a time-release capsule, for instance, liberation might be the very thing that limits how fast it starts working.
And I imagine the gastrointestinal tract is a pretty harsh environment for both liberation and absorption.
Oh, absolutely. I mean, just the simple mechanical issue of a pill getting stuck in the esophagus, even for a short time, can delay the effect, which is a big problem for urgent drugs. Or worse, it can cause actual damage to the lining.
And then it hits the stomach.
And it hits the stomach acid.
Yeah.
That highly acidic environment, that low pH, can just chemically degrade sensitive drugs before they even have a chance to get to the small intestine, which is where most of the absorption actually happens.
So with all these obstacles, if I swallow, say, a 200 milligram pill, how do we ever know what fraction of that actually makes it past all those barriers and into the bloodstream, intact and ready to work?
That's where we rely on a key metric called bioavailability. We abbreviate it as a capital F.
F for fiction.
You can think of it that way. Bioavailability is the fraction of the administered dose that reaches the systemic circulation unchanged. It's really the gold standard for measuring how successful absorption was. If a drug gets absorbed well and avoids being immediately broken down, its F value is high.
And I'm guessing that an intravenous, an IV injection, is the ultimate benchmark here.
Correct. IV administration just bypasses that whole liberation and absorption process completely. So 100% of the dose reaches the circulation instantly. That makes IV the gold standard reference point, where F equals 1.
So any other route, a pill, a skin patch, a muscle shot, it's always going to have an F value of less than 1.
Often substantially less, yeah.
How do pharmacologists actually figure out that F value for a pill? I mean, it seems tricky considering a drug might be absorbed slowly or in little bits and pieces.
Well, we use a method that involves something called the area under the curve, or AUC. We take multiple blood samples over time after someone takes the pill, and we plot the plasma concentration on a graph.
And you get a curve that goes up and then comes back down.
Exactly. Then we just integrate the area under that curve. We compare this AUC to the AUC we get from giving the same dose intravenously, the ratio of those two areas. That gives us the bioavailability F as a percentage or a fraction. It's a really elegant way to account for both the amount absorbed and the rate it appears over time.
Okay, this is where the body throws up its biggest roadblock for so many oral drugs. First-pass phenomenon, or FPE. What is this biological filter, and why does it hit some drugs so much harder than others?
The FPE is a a really effective evolutionary defense mechanism. It's a phenomenon where a medication gets chemically changed or metabolized and basically partially inactivated before it even gets a chance to reach the main circulation or its target.
A mandatory pre-screening checkpoint.
That's a great way to put it, yeah.
And that checkpoint is primarily the liver, right? Through the portal system.
Yes. All the blood that drains the GI tract where these oral drugs are being absorbed, it's all routed directly through the hepatic portal vein system to the liver before it goes anywhere else. And the liver is just packed with metabolizing enzymes, especially the cytochrome P450 family.
So it acts like a biochemical filter.
It does. It converts many of these drugs, which are often lipophilic, into more polar, inactive, water-soluble metabolites that are easier to get rid of.
But the sources we looked at noted the FPE isn't just the liver. The drug can get metabolized even before that.
That's a crucial point. The FPE really starts earlier. Metabolism can happen right there in the walls of the GI tract itself, by enzymes in the gut wall, or even by digestive enzymes. The lungs, the vasculature, they can also contribute, but the liver is definitely the main player.
So the outcome is the same no matter where it happens. Less active drug makes it through to do its job.
They're significantly less.
So if a drug is really susceptible to this first-pass effect, the clinical consequence is huge. The oral dose has to be way, way larger than an IV dose just to push a therapeutic amount past that filter.
That's the dosing imperative right there.
Yeah.
For a drug with a high hepatic extraction ratio, meaning the liver just yanks a huge fraction out in a single pass, the oral dose can be 10, maybe even 20 times the required IV dose.
What are some examples of that?
We see this with morphine, for sure. Its oral dose is far higher than its injected dose because a huge percentage gets metabolized on that first pass. Drugs like alprenol, pentazocine, mercaptopurine, they all face a pretty considerable FPE.
This must be a logistical nightmare for drug developers.
Yeah.
So how do clinicians get around this system when they need really rapid action?
They change the route of administration to physically avoid that portal circulation. The classic strategy is the sublingual route, placing the medication under the tongue.
Because the blood vessels there are different.
They're different. The tissue under your tongue has this dense network of blood vessels that drain directly into the systemic circulation. It completely bypasses the gut and the liver.
And the classic example of this is nitroglycerin for angina.
Precisely. Nitroglycerin is highly lipid-soluble, so it just zips right through the oral mucosa. When you give it sublingually, it hits the systemic circulation fast enough to stop an angina attack in its tracks. It achieves that rapid onset because it completely dodges the first-pass effect.
That is a beautiful piece of physiological engineering. Can you contrast that with a similar drug that doesn't work that way?
Yeah, we can contrast it with isosorbide mononitrate, or ISMN. Now, ISMN has very low susceptibility to FPE and really high oral bioavailability. It's a very efficient pill.
So most of it gets through when you swallow it.
Most of it does, but because it still has to go through the standard oral absorption process, its onset is just too slow. You can use ISMN for chronic prevention, but you can't use it in an emergency to treat acute angina. For that, you need the speed of the sublingual route.
So the route of administration is this calculated decision based on both efficiency and the required speed. But our sources also highlighted a really revolutionary approach. What if you just block the first-pass metabolism?
This is the genius breakthrough involving dextromethorphan.
The cough suppressant.
The cough suppressant, right. But researchers found it had promise for treating pseudobubar affect, a neurological condition. The problem was when you took it orally, it was almost completely inactivated on the first pass by one specific liver enzyme, CYP2D6.
So the body had this built-in off switch for it.
It did. That CYP2D6 enzyme just chewed it up too quickly for it to build up any real systemic concentration. So the therapeutic breakthrough was to co-administer it with a tiny, tiny dose of quinidine.
And what does quinidine do?
Quinidine is a potent inhibitor of that specific enzyme, CYP2D6. So by giving this minimal dose, you selectively, safely, and effectively just shut down the first-pass metabolism of the dextromethorphan.
The quinidine acts like a shield.
It's like a sacrificial lamb, yeah. It binds up the enzymes so they can't get to the dextromethorphan. This just dramatically increases the systemic concentration of the active drug, allowing it to reach therapeutic levels. And the fact that this combination is now FDA approved, it just shows how a deep understanding of these pathways lets us essentially hack the body's defenses for therapeutic gain.
That is fantastic. But as powerful as these calculations are, the sources stress that the extent of the FPE isn't a fixed number for every single person.
And this is the crucial part for clinical practice, the variability. The FPE extent differs widely from patient to patient. It's why individualized dosing is so essential.
And what causes that variability?
A lot of things. Genetic polymorphisms in their enzyme systems. Some people are just born fast metabolizers, others are slow. Gender, age, even GI motility, which changes how fast the drug gets to the liver.
So if you're a slow metabolizer, that normal oral dose, which is designed to account for a massive first pass, that could suddenly become toxic because too much active drug is getting through.
Precisely. You've just described the danger. And that's why for drugs with a high FPE and a narrow therapeutic window, we can never just rely on population data. We have to monitor blood concentrations to make sure the patient stays safely within that window, accounting for their unique physiology.
That leads us directly into Section 2. Drug travel. We're talking volume of distribution and these plasma protein partners. So once the drug gets past that first pass filter and into the systemic circulation, the next challenge is where it goes. And this is defined by the volume of distribution, or VED.
It's one of the most conceptually tricky numbers in all of pharmacokinetics, but it's absolutely vital. Conceptually, VED is an apparent sort of fictitious volume that describes how widely a drug is spread throughout the body.
Okay, so mathematically,
Right.
how is it defined?
Mathematically, it's the total amount of drug in the body divided by the measured plasma drug concentration.
Okay, so why is it always called apparent or fictitious? I mean, if I know how much drug I put in and I measure the concentration in the blood, shouldn't the volume I calculate be the real fluid volume of the body?
That's the core misunderstanding we have to clear up. See, if the drug only stayed in the plasma, then yes, the VED would equal the plasma volume, which is about 3 liters. If it spread out through all your body water, it would be around 42 liters. But most drugs don't do that.
They leave the plasma.
They leave the plasma and they bind to tissues, fat, muscle, organs.
Let's use that analogy from the sources, the one about the tub of water and the sponge.
Perfect. Okay, imagine you have a tub with exactly 40 liters of water. You drop 400 milligrams of a drug into it. If the drug just dissolved perfectly, the concentration would be 10 milligrams per liter.
Sure.
Simple.
Right.
Now you drop a big sponge into the tub. That sponge represents your muscle or fat tissue, and the sponge soaks up and binds 360 of those 400 milligrams. So now only 40 milligrams are left floating free in the 40 liters of water.
So the measured concentration in the water, the plasma, is now only 1 milligram per liter.
Exactly. So if you now calculate the VD using that measured concentration of 1 milligel and the total amount of drug you put in, which was 400 milligrams, the resulting volume of distribution is 400 liters.
400 liters, even though the tub is only 40 liters.
Exactly. That 400 liters is the apparent volume required to hold all that drug if the concentration was uniformly 1 milligel everywhere. Because the drug bound to the sponge, the concentration in the plasma plummets, making the calculated VD look huge.
So a large VD tells us one thing very clearly. The drug has left the circulation and is hiding out in the tissues.
It's a measure of tissue avidity, yeah. A high VD means high tissue binding, high lipid solubility, and generally lower plasma concentrations. And VD is crucial because it's the key factor we use when we calculate the necessary loading dose, which we'll get to later.
Can you give us some real-world examples of drugs that sort of hug the plasma versus those that just disappear into the tissues?
Certainly. Take a drug like cetrorelix. It's a peptide drug. It has a very low VD, around 0.39 liters per kilogram. So for an average person, maybe 30 liters total. This is typical of large, charged, or highly protein-bound molecules that can't easily cross cell membranes.
They're basically locked in the central compartment.
They really are. Now, contrast that with chloroquine, the antimalarial drug. It has a staggering VD of about 140 liters per kilogram, far, far greater than total body volume. Chloroquine is highly lipophilic, it loves fat and cell membranes, so it distributes extensively into cells and adipose tissue where it's tightly sequestered.
That comparison is stunning. It really illustrates the drug's preference. And this distribution is heavily influenced by our next topic, the critical role of plasma protein binding.
This is one of the most clinically relevant factors there is. In your blood, a drug exists in this equilibrium state. It's either bound to a plasma protein or it's free. And that equilibrium is everything.
And it's only the free drug that matters.
Yeah. Only the free, unbound drug can do anything. It's the only part that can cross cell membranes, bind to receptors, exert its pharmacological effect, or be eliminated by the liver or kidneys. The free drug concentration is the number that correlates most closely with clinical effect and just as importantly, with toxicity.
So the bound drug is just inactive baggage, basically.
It's inactive baggage. The plasma proteins act as this temporary carrier system, a reservoir. This binding protects the drug from immediate clearance and limits its immediate access to tissues.
So which proteins are the most important partners in this little storage system?
We mainly rely on three types. First and foremost is albumin. It's the most abundant protein in the plasma, and it primarily binds acidic and neutral drugs. Albumin is characterized by having high capacity but low affinity.
Meaning it can carry a lot of drug, but it doesn't hold on too tightly.
Exactly. The binding is easily reversible. Then the second major player is alpha-1 acid glycoprotein, or AG. This one binds basic drugs, and it operates on the opposite principle of albumin. Low capacity but high affinity. And because it's an acute phase reactant, its concentration can shoot up during inflammation, which can really change things.
And the third type?
The third are the lipoproteins. These are important for highly lipophilic drugs. A drug like imipramine, for example, can be 75 to 95% bound just to lipoproteins. Understanding which protein binds the drug tells us how diseases that affect those protein levels are going to alter the drug's effect.
Okay, let's talk about the high stakes here. If a drug is heavily protein bound and something happens that alters that binding, what's the clinical consequence for the patient?
The consequences can be catastrophic, especially for drugs with a narrow therapeutic index. A reduction in plasma protein binding, whether it's from a disease or a drug interaction, immediately increases the fraction of free active drug. This just massively elevates the potential for toxicity.
Give us the classic terrifying example.
Warfarin is the textbook case. It's about 99% protein bound to albumin. So that means only 1% of the total measured concentration is actually active, preventing clots. Now imagine a patient develops a condition that slightly reduces their albumin, or they take another drug that displaces warfarin and the binding drops from 99% to just 98%.
The active drug fraction just doubled. It went from 1% to 2%.
Exactly. The amount of free active warfarin has doubled, which can lead to a potentially life-threatening increase in bleeding risk. The total concentration you measure in the blood might look only slightly off, but the active concentration has surged. It's why clinicians have to treat the free concentration, not the total.
So any condition that causes low albumin malnutrition, liver disease demands an immediate dose reduction for these types of drugs.
Absolutely. The sources specifically called out renal failure, or uremia. Uremia introduces substances into the blood that compete for those albumin binding sites. This decreases the binding capacity for acidic drugs like diazepam. So if you give a standard dose of diazepam to a patient in renal failure, the free concentration is much higher, and you have a huge risk of CNS depression and respiratory arrest. You have to cut the dose.
That's fascinating. It's not just that they can't excrete the drug, it's that the chemistry of their blood has changed the binding, and then you have the displacement interactions.
The displacement interactions are the pharmacist's nightmare. Take sulfonamides, the antibiotics. They can displace bilirubin from its binding sites on albumin. In a newborn, where the blood-brain barrier is still immature, this increase in free bilirubin can lead to kernicterus, which is a devastating form of brain damage.
Wow.
Or again, aspirin displacing warfarin. These are dynamic interactions where a little change in protein binding translates directly into severe clinical risk.
The lesson here is crystal clear. Volume of distribution in plasma proteins. They define the physical boundaries and the true drug exposure. Let's move on to Section 3, the dynamics of elimination. We're talking linear kinetics, clearance, and half-life. We've managed to get the drug in and distributed, but now the body has to get rid of it. And the predictability of this elimination process really dictates how easily we can dose the drug.
For the vast majority of drugs we use, the body follows linear pharmacokinetics, or what we call first-order kinetics. This is the predictable model. It just means the rate of drug elimination is directly proportional to the drug concentration.
In simple terms, the more drug you have, the faster your body removes it.
Precisely. It's a clean, safe mathematical relationship.
And what are the key properties that define this linear model?
There are a few defining characteristics. First, the elimination follows predictable exponential decay. Second, and this is key, the half-life is constant. It doesn't matter if the concentration is 100 or 10. The time it takes to cut that concentration in half is always the same.
Okay, constant half-life. What else?
Third, clearance remains constant across the relevant dosing range. And fourth, this gives us the big clinical advantage. Dose proportionality.
Dose proportionality. So if a patient's drug level is 50% too low, You can just increase the dose by 50% to get them to the target.
You can. That direct linear relationship is what allows us to safely and predictably titrate medications in the hospital.
But not all drugs play by these nice, clean rules. We have to talk about the danger of nonlinear kinetics, sometimes called zero-order kinetics.
Right. Nonlinear kinetics is what happens when the body's elimination machinery, the enzymes, the transporters get saturated, it's overwhelmed. When the drug concentration exceeds the capacity of that system, the body can no longer eliminate a fixed proportion of the drug per hour. Instead, it can only eliminate a fixed amount per hour.
So the rate of elimination becomes independent of the concentration. The system is maxed out.
It's maxed out, and this creates a massive clinical risk because predictability just vanishes. Drugs like alcohol, phenytoin, or high doses of aspirin are classic nonlinear examples. If you increase the dose of a nonlinear drug by, say, 50%, you might suddenly cross that saturation threshold. The elimination rate plateaus, but your input rate is now much higher.
And the drug concentration just skyrockets.
It climbs dramatically, unexpectedly, and often dangerously into the toxic range. This non-proportional spike is sometimes called the cliff effect.
If linear dosing is like driving in predictable traffic, nonlinear is like hitting a massive, sudden traffic jam.
That's a perfect analogy. The margin for error is tiny, making patient monitoring absolutely critical for these agents. Now let's define the engine of elimination. Clearance, or CL.
We've said clearance determines the elimination rate, but let's get a formal definition.
Clearance is defined as the volume of fluid, usually we're talking about plasma, that is completely cleared of the drug over a unit of time. So the units are something like liters per hour. It's important to think of it as a fictitious volume being cleared, not the total amount of drug being removed.
And clearance is what determines the maintenance dose we have to use, because it dictates how fast we need to replace what the body removes.
Precisely. Clearance is mostly influenced by blood flow to the kidneys and liver and the health of those organs. The rate of drug removal, what we call rate out, is just clearance multiplied by the drug concentration. If your kidneys fail and your clearance drops, your maintenance dose has to drop, or the drug will inevitably accumulate.
And that clearance rate, combined with the volume of distribution, gives us our final fundamental parameter, the drug half-life.
Right. The half-life, the time for the serum concentration to decrease by 50%, is determined by that balance between how spread out the drug is, VD, and how efficiently the body removes it, clearance. The core formula is essential. 12 equals 0.693 times VD divided by clearance.
Okay, let's break that equation down. VD is in the numerator, so half-life is directly proportional to VDER. If the drug is stored everywhere in the tissues, a high VVDER, the half-life is long.
Exactly, it makes sense. If the drug is hiding out in the tissues, it takes the body longer to pull it out and eliminate it. And clearance is in the denominator, so half-life is inversely proportional to clearance. If your body clears the drug twice as fast, the half-life is cut in half.
This formula is really the cornerstone of PK. It lets us predict the kinetics. And clinically, it dictates how long we have to wait for a drug to fully work or fully disappear.
That's its clinical significance, absolutely. It tells us two vital things. First, the time needed to reach a steady state after starting a drug. Second, the time required for elimination. That takes about 4 to 5 half-lives to get 94 to 97% of a drug out of your system.
So for a drug like morphine, with a short half-life of 2 hours, it's pretty much gone in 8 to 10 hours.
Right. But for a drug like amiodarone, which has a half-life measured in weeks, the effects are going to linger for months. Understanding clearance and VDA lets us predict these critical time markers.
That's a perfect pivot to Section 4, hitting the target steady state and the loading dose strategy. The ultimate goal isn't just a single dose. It's keeping the drug safely and consistently inside that therapeutic window.
And that maintenance goal is defined by the steady state, or SS steady state is the point when the rate of drug input, whether it's a continuous infusion or intermittent pills, is exactly equal to the rate of drug elimination. Rate in equals rate out.
So at this equilibrium point, the average plasma concentration just holds steady.
It holds steady. Now, if you're dosing intermittently, like a pill every 12 hours, the concentration won't be perfectly flat.
Right, it'll go up and down between doses.
Correct. It oscillates between a peak right after you take it and a trough just before the next dose. But the average concentration over that dosing interval remains constant at steady state.
And the time it takes to get to that equilibrium is a direct function of the half-life.
Yes. It takes approximately 5 half-lives to reach true steady state, where you're at over 97% of the maximum steady state concentration. And this rule holds true whether you're starting a new drug or changing the dose of an old one.
Okay, so if a drug has a long half-life, let's say 48 hours, we're talking about waiting 10 days just to see the drug's full effect. If a patient is critically ill, that wait is completely unacceptable.
Absolutely unacceptable. And that long wait is what drives the loading dose imperative. A loading dose is a single, much larger dose than the maintenance dose, and it's designed to quickly fill up that volume of distribution and get you to the desired therapeutic concentration almost immediately. It's a shortcut.
It bypasses that 5 half-life lag time.
It does. The maintenance dose replaces what the body clears, but the loading dose fills the tank right away.
So how do we calculate that maintenance dose to keep the steady state consistent?
Well, for a continuous infusion, it's simple. The steady state concentration just equals the infusion rate divided by the clearance. For oral or intermittent dosing, the maintenance dose is calculated to replace what's cleared between doses. The formula is MD equals steady state concentration times clearance times the dosing interval divided by bioavailability.
And looking at that formula, you can see that clearance is the main physiological driver there. The faster the body clears it, the bigger the maintenance dose has to be.
It does. Now, connecting back to the loading dose, we need an LD in so many critical situations. For example, in status epilepticus, an emergency loading dose of an anticonvulsant like levetiracetam is essential to stop the seizing now. Or for chronic heart conditions, drugs like amiodarone and digoxin have such long half-lives that an LD is mandatory to even start treatment promptly.
And the math behind that loading dose relies most heavily on which PK parameter?
The volume of distribution. The loading dose formula is basically LD equals the volume of distribution times your target steady state concentration, divided by bioavailability.
So the V defines the size of the tank we need to fill up.
It does. If the VED is massive, like for chloroquine, we know the drug is hiding in the tissues, so we have to give a really big initial dose to saturate all those tissue binding sites up to the therapeutic concentration. Once the VED is full, the smaller maintenance doses only need to keep up with what's being lost through clearance. It's a calculated strategy to manipulate time and space inside the body.
We also saw the example of difidilide for atrial fibrillation, which requires a loading dose, but with extreme caution.
That's a really high-risk initiation. Clinicians have to meticulously monitor the patient's kidney function, specifically their creatinine clearance, and the QTc interval on their EKG. If that loading dose is too high because of unknown renal impairment, the concentration will spike, and it can lead to fatal arrhythmias. This is a perfect example where the PK calculation for the LD is literally a matter of life and death.
That urgency really highlights the limits of these simple models. Let's dive into Section 5. Advanced pharmacokinetics compartments and clinical curves. So far, we've kind of treated the body as one big tub of water where the drug is uniform, but real distribution is way more complex.
The single compartment models are great for steady state, but they fail to capture the immediate dynamics right after a dose. Most drugs are better described by a two-compartment model. This model recognizes that the body is effectively split into two volumes that talk to each other.
Okay, tell us about these two volumes.
So first you have the central compartment, which we call $2. This is the highly perfused system. The blood, plasma, liver, kidneys, lungs. This is where you administer the drug, where it's eliminated, and critically, where you draw your blood samples from.
The second one.
That's the peripheral compartment, or $2. This includes the less perfused tissues, your muscle, your fat, your skin. This is often where the drug receptors and the storage sites are actually located.
So the drug goes into V1 quickly, and then it slowly moves over into V2 until eventually the whole system, the total volume, is saturated.
Exactly. And the rate at which the drug moves from V to D2 defines the distribution phase. If this phase is really fast, the concentration in V1, the blood plummets rapidly, even if no drug has actually been eliminated from the body yet. And this distinction between distribution and elimination is clinically enormous.
Let's use that stunning case from the sources. Thiopental, the anesthesia induction drug. This really shows why ignoring V2 can lead to huge clinical errors.
Thiopental is a great example. It's a highly lipophilic drug. It has a large final VED, about 175 liters, but its initial central volume, V1, is only about 20% of that. So when we give a fast IV bolus, the concentration in V just skyrockets instantly, hitting the level needed for immediate unconsciousness.
The patient is knocked out in seconds.
Yes. But because its distribution half-life is incredibly fast, less than an hour, the drug molecules immediately start moving out of that central compartment and into the peripheral compartment, like fat and muscle. Within 30 minutes, the plasma concentration in V tall layer has dropped back below that critical threshold.
So, and this is the aha moment.
Yeah.
The patient wakes up quickly, not because the body cleared the drug, but because the drug just redistributed out of the brain and into storage.
That is the crucial insight. Thiopentol is only perceived as a short-acting drug because of this rapid redistribution. Its true elimination half-life is around 20 hours. For a brief surgery, we don't care about that 20-hour half-life because redistribution is what ends the effect.
But what happens if a physician decides to use thiopentol for a prolonged infusion, maybe in the ICU, to manage seizures or something?
If you run that infusion for hours or days, you eventually saturate the peripheral compartment, V2H2s, as well. The drug reaches a true steady state across all 175 liters of its VD. So when you finally stop the infusion, the drug can't redistribute anymore to lower the concentration. The only way out is slow, true elimination.
So the patient's recovery time suddenly switches from being governed by the fast 40-minute distribution half-life to the slow 20-hour elimination half-life.
Precisely. That patient is going to take many, many hours, maybe a full day or more, to wake up, completely dependent on the body's slow clearance. The clinical management is a whole different ballgame based on the duration of use.
Now let's look at the other classic example, digoxin, the heart drug with that very narrow therapeutic range.
Digoxin provides a different but equally important warning. It has an immense VD, over 600 liters in an average person, and a long elimination half-life of around 43 hours. Its distribution phase is also slow, taking about 30 minutes.
So if a doctor gives a standard IV loading dose, what happens to the measured plasma concentration?
Well, because you're giving this huge dose to fill up that massive VD, the drug concentration in the central compartment, V$1, instantly peaks to dangerously high levels, maybe 4 micrograms per liter, when the safe range is 0.5 to 2.0.
But the patient might not show any immediate signs of toxicity, which creates this paradox.
The paradox is that the active sites on the heart muscle, they're in the peripheral compartment. The drug hasn't had enough time to get there yet. The high peak we measure in the plasma is just a transient concentration in V$1, and it's a dangerous, temporarily misleading picture of the true drug exposure at the tissue level.
So if a nurse draws a blood sample 10 minutes after that IV bolus, they get a toxic number even if the patient is fine, which could lead to a totally unnecessary and wrong change in management.
That is the critical risk, to make sure the plasma sample is representative of the true effective concentration at the tissue site, meaning the central and peripheral volumes have equilibrated. Clinicians have to follow a strict lag time. Blood samples for digoxin should not be drawn for at least 2 hours after an IV dose.
And if the patient is taking oral digoxin, that required sampling time is even longer, right? Like 4 to 6 hours?
Yes, because you have to wait for the drug to absorb and distribute. These two case studies just confirm that dosing is a three-dimensional chess game involving time, physical space, and elimination rate. Understanding these compartments is what separates safe practice from guesswork.
Finally, that brings us to Section 6, the clinical imperative. We're talking about pharmacokinetics in special populations and interprofessional care. We've been discussing average patients, but the real challenge is that the ADME parameters we calculate, especially clearance, can be wildly different based on unique patient factors.
Variability is the norm, not the exception. The standard dosing you see in a drug reference is based on statistically estimated PK parameters from healthy volunteers. But individual factors, age extremes, gender, genetics, and of course underlying organ disease, all significantly alter a drug's disposition.
So automated dosing algorithms are really just a starting point.
They're just a starting point. Individualized adjustment based on the clinical picture is always necessary.
Let's focus intensely on renal impairment, since the kidneys are the primary route of excretion for so many drugs.
Right. The kidney is responsible for clearing drugs and their active metabolites. When renal function declines, the decrease in excretion is predictable, and it almost always means you have to reduce the dose to prevent accumulation and toxicity.
But the sources noted that renal impairment affects more than just E for excretion.
Yeah.
It can mess up the whole ADME picture.
It creates systemic chaos, yeah. Impaired renal function, uremia, can actually decrease drug absorption from the gut. As we already discussed, it alters the plasma proteins, changing the binding of acidic drugs, which increases the free fraction. And it can even change non-renal metabolic pathways in the liver and gut. It's a domino effect.
So how does the FDA guide PK studies for new drugs to account for these changes in kidney function?
The FDA requires dedicated PK studies when a drug or its active metabolites are substantially eliminated by the kidneys. The rule of thumb is if the fraction eliminated unchanged in the urine is 0.3 or greater.
So if 30% or more of the dose comes out through the urine, you have to study it in kidney disease.
You do. And for therapeutic proteins and peptides, they require studies if the molecular weight is relatively small, specifically less than 69 kilodaltons, because larger proteins generally aren't cleared by the kidneys anyway.
In clinical practice, how is renal function categorized for these studies or for dosing?
We use standard clinical guidelines based on estimated glomerular filtration rate, or eGFR. The typical classification has 4 groups: normal, which is 90 millil/minute or higher; mild impairment, which is 60 to 90; moderate, 30 to 60; and severe kidney failure, which is less than 30.
This brings up a really crucial technical detail from the sources. Why do we have to be so careful about the units of GFR when we calculate a dose?
This is a point of frequent clinical error, so it's worth emphasizing. When a lab reports a patient's eGFR, it's often indexed to body surface area, or BSA. The report will say ml/minute 1.73 milliliters. This normalizes the reading for body size, which is great for assessing general population health.
But that index number is wrong for drug dosing. Why?
Because drug clearance is an absolute volume removed from that individual. So drug dose recommendations must be based on the individual's absolute GFR, just in ml/minute, not indexed to BSA. If a clinician mistakenly uses the index number, they could dramatically under or overdose the patient. You have to use the absolute value.
That is a critical safety distinction. And when using the Cockcroft-Gault equation to estimate creatinine clearance, especially in obese patients, we have to adjust the weight.
Yes. For overweight and obese patients, using their actual body weight can artificially inflate the estimated clearance because creatinine is a product of muscle mass, not fat. So using metrics like ideal body weight or adjusted body weight gives a much more accurate and therefore safer estimate for dosing.
Okay, let's talk about patients on renal replacement therapy, like dialysis. This adds a whole external clearance mechanism.
Right. When RT starts, the dose changes again because the machine is now helping to clear the drug. Studies for intermittent hemodialysis, or IHD, have to include periods when the patient is on dialysis and off dialysis. We measure things like blood flow and dialysate flow to calculate the dialytic clearance, which is how much drug the machine itself removes.
And for critically ill patients on continuous renal replacement therapy, or CRRT, the complexity ramps up even more.
With CRT, you have continuous clearance. The dosing recommendations there have to be based on the specific intensity of the CRT regimen, the blood flow, dialysis flow, and ultrafiltration rates. Those parameters directly determine how much drug is being removed per hour. If the ICU team changes the intensity of the machine, the drug dose must be recalculated immediately.
We focused heavily on the kidneys, but just to round this out, what about the complexities of liver metabolism in, say, a patient with cirrhosis?
That's a vital point. The liver is the main site of metabolism. Liver disease, like cirrhosis, impairs the liver's ability to metabolize drugs, especially those with high first-pass effect. If the P450 enzyme activity is reduced, 2 things happen. The bioavailability, F, goes up, and the clearance, CL, goes down. Both lead to higher and more sustained drug concentrations.
So liver failure requires a dose reduction because of both higher absorption and lower clearance, often leading to a much longer half-life.
Exactly. The half-life equation confirms it. Low clearance equals long half-life. The danger in these patients is often chronic accumulation. It just underscores that every part of the ADME framework is vulnerable to disease.
Given all this variability, the technical calculations, the severe consequences of error, this clearly requires a coordinated team approach.
Absolutely. Pharmacokinetics really underpins the need for interprofessional team monitoring. We know prescription errors are unfortunately common. Some estimates say around 11% of prescriptions have an error, so checks and balances are paramount, especially during high-risk times like transitions of care.
And what are the specific roles that team members play in applying these PK concepts safely?
The pharmacist is really the PK expert on the team. They're verifying dosing, checking for interactions, and monitoring blood levels for narrow therapeutic index drugs like gentamicin. The nurses are on the front line, monitoring for clinical effectiveness and side effects, and ensuring the timing of doses is precise. And the computerized prescribing systems have to have algorithms built in to flag dosing errors based on the patient's specific weight and renal function.
So it's that collective safeguard that ensures the complex dynamic math of ADME is correctly applied to the volatile, unique physiology of the individual patient. We've truly covered the entire journey today, from the first-pass effect, which often tries to stop the drug from even getting in, to the volume of distribution, which determines the physical space it occupies, and clearance, which sets the clock for elimination.
The key takeaway, I think, for the learner is that safe drug administration is a precise logistical challenge. It's all aimed at maintaining that perfect, steady state where the rate of input exactly matches the rate of elimination. It requires us to quantify every single barrier and every pathway the drug encounters.
And drug concentration, we now know, is not a fixed light switch. It's a dynamic, fluctuating curve, constantly being manipulated by time, by enzymes, by proteins, and by those crucial physiological filters like the liver and kidneys.
And we use powerful tools, like loading doses, to quickly jump that concentration curve up to the therapeutic level, bypassing the 5 half-life weight required by natural kinetics.
Which brings us back, full circle, to that digoxin paradox. We give a large IV loading dose, and for the first couple of hours, the measured concentration in the plasma, in the central compartment, it appears dangerously toxic. Yet the patient is often clinically stable because the active drug hasn't fully diffused into the tissue sites yet. The central compartment concentration is, for a time, a misleading measure of the drug's true effect.
And that raises a really important question for you, the learner, to think about as medicine becomes more personalized. If plasma concentration, measured in the central compartment, is not always the true or immediate indicator of efficacy or toxicity, as the digoxin case clearly shows, what other more localized patient biomarkers or physiological responses should we be prioritizing over standard blood draws to truly personalize medicine and understand the drug effect at the tissue level, rather than relying on a blood sample that temporarily tells a lie?
A fascinating challenge for the next generation of pharmacology. Thank you for joining us for this deep dive into the mechanics of drug dosing.